everyone. We are having an amazing day. Let me just say, you are a part of the largest health forum on African American health in this country. We have more than 2,000 people visiting with us today, engaging with us today. So we're making Black history during Black History Month. So kudos to us. Now we're going to talk about multiple myeloma. It's a disease that some of you have heard of, but may not know a lot about. Let me quote a statistic that is the most startling. While multiple myeloma only accounts for 2% of all cancers, it is the most common blood cancer in African Americans. African Americans account for 20% of all patients living with this disease. So it's something that we really need to become more cognizant of and aware of. So today's conversation with Dr. Neha Korde will help raise awareness, and she's a fantastic oncologist expert coming to us from Memorial Sloan Kettering. And now I'm going to read a little bit about her bio. Dr. Korde is a board certified hematologist specializing in the treatment of multiple myeloma and other plasma cell neoplasms. She has a particular research interest in early plasma cell disorders, including monoclonal gammopathy, sorry about that, Dr. Corday, of unknown significance, and smoldering myeloma, and understanding disease biology that may promote transition to frank symptomatic multiple myeloma in some individuals. And so now I'm going to turn this session over to Dr. Corday. Thank you for being here with us.
Thank you for having me. Hi, and thank you so much for that kind introduction. So on behalf of my colleagues in the multiple myeloma department at Memorial Sloan Kettering, I wanted to thank the organizers in Roslyn for highlighting multiple myeloma as an important cancer, a cancer that we know disproportionately affects Black patients and is very relevant to the topic of Black health. So I hope you find my talk somewhat informative. So here are my disclosures for my talk today. The goals for today's talk is really to cover a few different topics on multiple myeloma and focus on how it pertains to the health of Black patients specifically. The first is to provide a disease overview, and I'll go over a clinical presentation of the patient. Second, I'm going to move on to how myeloma is really relevant to Black patients as we discuss risk factors for the disease. And finally, the last portion of my talk, I'm going to be talking about myeloma treatment approach and gaps in health outcomes that we have seen in the field. So let's briefly talk about what multiple myeloma is and where it actually stems from. Multiple myeloma comes from a malignant or cancer-causing clonal plasma cell. What is a plasma cell? Well, a plasma cell is a specific type of immune cell made in your bone marrow. The purpose of a healthy plasma cell is to produce antibodies, otherwise known as immunoglobulins. And these immunoglobulins, they help the immune system to coordinate an attack when the body is fighting off infections. Under normal circumstances, the plasma cells live in the bone marrow cavity in really low amounts, usually comprising up to 5% or less of your entire bone marrow. Now, we don't know what the first inciting event of why a plasma cell that's normal and healthy turns cancerous or malignant, but we do know a couple of things. Number one, it probably takes an accumulation of different mutations to turn the healthy plasma cell into a clonal or malignant one. Myeloma disorders is really a spectrum of disease states going through different stages, moving from low disease plasma cell disorders such as MGUS and smoldering myeloma to more symptomatic ones such as multiple myeloma to even highly aggressive relapsed forms. Each stage along the way, we see a prevalence of different mutations that can increasingly worsen or change, and essentially affecting the nature of the disease itself. And it's important that it's important to realize that multiple myeloma is actually always preceded by a precursor disease state. And that's what MGUS and smoldering myeloma truly is. It's a precursor disease state to multiple myeloma. Multiple myeloma doesn't happen de novo or completely brand new. It always comes from MGUS or smoldering. And now this is really important because it implies that it can be caught early and tracked along the way. And we know that patients that have knowledge of their MGUS and smoldering diseases, they tend to have better outcomes if they ever actually progress to multiple myeloma at diagnosis. Detection is done through a simple blood test, and your doctor won't really routinely screen for multiple myeloma. In fact, they usually only do it when they have some kind of clinical suspicion as to why they might be ordering the test. What is the screening test that they're actually doing? So earlier I told you that normal healthy plasma cells produce antibodies. Well, malignant myeloma plasma cells produce antibodies as well, it's just in large amounts. And these large amounts of antibodies are called M protein or monoclonal protein. The screening test that they do is really looking to detect an excess amount of monoclonal protein. This monoclonal protein, it can be detected in your blood as well as in your urine. And if the disease is determined to be severe enough, sometimes your doctor may need to perform a bone marrow biopsy to ascertain the level of myeloma cells in the bone marrow. And this can help determine the diagnosis of MGUS, smoldering, or multiple myeloma. The hallmark difference between precursor disease states and multiple myeloma has to really do with organ damage. MGUS and smoldering don't have organ damage and is usually watched or observed by their doctors. On the other hand, a multiple myeloma diagnosis is made when there's direct evidence that the myeloma cells are starting to affect other organ systems. And it does this through a variety of different mechanisms. For instance, the abnormal M protein that's produced by the myeloma cells, they could go ahead and compromise kidney function as well as cause interference in nerve conduction. Patients can often experience sensory dysfunction as a symptom. The abnormal excess of myeloma cells can skew or alter the immune system, making patients more prone to infections. And while doing so, it often can cause the bone marrow to shut down production of normal, healthy bone tissue, possibly causing anemia and fatigue. Additionally, the cells in the bone marrow can cause an unhealthy destructive process of bone turnover, causing patients to have brittle bones, more prone to fractures, as well as thinning out of these bones. This destruction of the bone can actually cause patients to have a high level of calcium, and that can even affect patients, possibly causing an altered mental status or having GI issues. Now that you know what myeloma is, let's talk a little bit about how prevalent it is. And this is something that Rosalind was speaking to earlier. Myeloma is the second most common hematologic malignancy in the United States after non-Hodgkin's lymphoma and accounts for 2% of all cancers. The incidence of myeloma affects roughly 32,000 people annually in the United States. However, among African Americans, it's actually the most common hematologic malignancy. It occurs disproportionately in Black patients compared to all other racial and ethnic groups. And we're going to explore why this may be the case. A number of different risk factors have been identified for MGUS and myeloma, including older age, male gender, and even certain environmental exposures that we found. For instance, post 9/11 first responders, as well as Vietnam War vets that were exposed to Agent Orange. Importantly, there's also a genetic component to this. We know that first-degree relatives that have been affected by myeloma disorders have a higher risk of developing plasma cell disorders compared to the general population. This familial genetic component may give us a clue as to why we also see 2 to 3 times higher risk in Black individuals developing MGUS and myeloma conditions compared to other groups, suggesting that there may be an ancestral or genetic predisposition to developing myeloma in individuals of African and West African descent. And this has actually been demonstrated in various population studies. Scientists have done studies to evaluate mutation patterns in the myeloma cells for patients of African ancestry as well as European ancestry to compare. There does seem to be some differences that they've picked up. Myeloma patients of African ancestry have a higher mutation load of certain non-hyperdiploid IgH translocations, including one that's called translocation 1114. And why is this important? Translocation 1114 mutations in myeloma tend to be more of a chronic indolent disease course. And recent studies suggest that myeloma patients that carry this particular mutation may be uniquely susceptible to certain targeted agents. So patients that have this mutation may actually benefit from a certain type of chemotherapy. Digging a bit deeper, genome-wide association studies using a more complex and comprehensive approach demonstrate that there actually is significant overlap between myeloma patients of African and European ancestry. And the same 23 common loci are involved in both cohorts. This suggests that the biological reason for why Black patients have a higher risk of myeloma still actually remains a mystery, and more scientific research is needed to really address this question. Moving on to therapies, it's important to realize that treating myeloma is really a multidisciplinary approach. It requires effort on everyone's part to ensure a total 360-degree approach to optimizing care for the patient. And it really begins and ends with knowledge. While myeloma is considered incurable currently, it's very treatable. And as research progresses, there's always hope for a cure. There are really 4 pillars of treatment approach in my mind that we should consider. The first is patient advocacy. So forums like this to get knowledge to everybody that may potentially be a patient. Finding a myeloma expert who you can see or have your local oncologist partner with is also important. Talking through all treatment options with your doctor and your care team, consider all treatment options, including standard of care and clinical trials, and really seeking state-of-the-art diagnostics to help detect and help guide your care plans. Science and clinical research is driving progress in myeloma. And over the last 2 decades, we are seeing novel therapies being developed and pushing the response rates to unprecedented levels. In some cases, patients are even approaching 100% overall response rates, and the disease can be suppressed to even undetectable or minimal residual disease negative levels. Diagnostics are another area where we are making improvement, and technology has certainly increased our sensitivity of detection. For instance, at MSK, we're investigating a technique called mass spectrometry so we can detect the monoclonal protein at lower levels. And furthermore, we and other centers have pioneered methods that detect myeloma-specific bone lesions by using radiolabeled dyes that are unique to myeloma. Through all of this progress of novel therapies and innovative diagnostics, myeloma certainly survival-wise is improving. And that's what this graphic is showing. It's taken from the US SEER database, showing that myeloma patients are indeed living a lot longer compared to even just a couple decades prior. So we're making improvement and progress. And despite this, when we dig a bit deeper, we find that the mortality among Black myeloma patients is still 2 to 3 times higher compared to other races and ethnicities. And some of this may be due to the higher prevalence rates that we talked about earlier, but that's not just the full story. So let's explore a little bit further. What we know is that there's a disparity in disease presentation among Black myeloma patients. Black myeloma patients tend to present at younger ages as well as higher disease burden states. The all-cause mortality is high in Black myeloma patients, but the myeloma-specific mortality is lower compared to other races. What does this mean exactly? Black myeloma patients we know are affected more likely by comorbidities like diabetes, cardiovascular disease, kidney disease, and it's actually possible that these other comorbidities could be contributing to the overall mortality in Black myeloma individuals. Access is another issue that could be contributing to mortality. This is a study where the authors found that 31% of African American myeloma patients underutilized intravenous and injection chemotherapy compared to other races and ethnicities. And it should be noted that IV and injections need to be given at highly specialized treatment centers. However, when the authors looked into oral chemotherapy pills, they saw no such disparity. So the take-home message is that this may be a reason of lack of access to care, logistics, and location to treatment care centers. Furthermore, we've also seen that Black and Hispanic myeloma patients have had a delay in initiating care in the past few decades compared to white myeloma patients. And in this graphic, we see a gap in initiation of care over the last few decades. More recently, it seems as if the gap is closing. However, evidence of it still exists. Delay in therapy initiation may be another reason why we're seeing high mortality. Here's a bright spot though. Once treatment is initiated and appropriate care is found, survival outcomes might actually be better. So this graphic is looking at outcomes in myeloma patients after autologous stem cell transplant, which is a common therapy that we use in treating myeloma patients, and actually found that once African American patients received transplant, their actual expected survival outcomes are indeed better compared to other races and ethnicities. So again, the key is starting care and seeking that care. Finally, what we also know is that Black patients are overall underrepresented in clinical trials. This is not just myeloma specific, but across the board in all oncology clinical trials in general. And in fact, only 4 to 6% of trial participants are African American in the United States. This is important because we need more heterogeneity in our trial participants to really understand how therapies work. This underrepresentation may limit the validity of the results. And there are barriers that exist with clinical trial participation. However, these barriers can be overcome by continuous engagement between communities and doctors. And a lot of it starts with trust. And I know that that's not easy to come by, but keep asking questions of your doctors, continue to engage in forums such as this one. And if you're considering participating in a clinical trial, ask your doctor about all of your options. Remember to be open to new possibilities, and remember that trials are necessary for new scientific discovery and research. They really help your doctors help you. So I wanted to end on a few points that I wanted to highlight about multiple myeloma. Myeloma is a cancer of the plasma cell that affects different organs. It is 2 to 3 times more common among Black myeloma patients, although we certainly see common mutation patterns, but there's no definitive explanation for why higher prevalence rates are noted. Black myeloma patients tend to present at a younger age with higher disease burden states, and mortality is higher among Black myeloma patients. It's not just necessarily only because of the higher prevalence rates, it's probably more complex than that. And it may also be related to access of care, treatment initiation, and higher comorbidities. Some studies are even suggesting, though, if treatment is not delayed and appropriate care is instituted, the clinical outcomes in Black myeloma patients may actually be better compared to other races and ethnicities. Appropriate treatment for myeloma starts with seeking care, getting the facts, and arming yourself with knowledge. So just be open to all of that and ask your questions to your doctors. Thank you for your attention.
Wonderful. Now, I think we do have time for a few questions. All right, let me just read a couple. Um, what effects does radioactive seed implantation have on being diagnosed with this type of cancer?
We don't know the direct answer to that question. As far as we know, radiotherapy doesn't necessarily increase the risk of MGUS or myeloma conditions. So we're not seeing that added increase as far as I'm aware of.
Okay. How is the general public supposed to identify novel treatment centers and innovative care? Great question, Dee.
That's a great question, by the way. I think that one is, it depends on where you live. Start with your local oncologist. If you have academic centers that are interested in research, there's also great number of platforms out there like International Myeloma Foundation and different organizations, MMRF, Multiple Myeloma Research Foundation. These are myeloma patient advocacy groups that can really help you find an expert in your care, because I think one of the things that we realize is that it takes a village to treat a myeloma patient. You really need not just your local oncologist, but even that high level expert care is really going to help you.
Now, another question. Has there been an improvement in immunotherapy for multiple myeloma?
Great question. There's just a plethora of research going on right now, and it's an exciting time for multiple myeloma. We're actually using immunotherapies currently in clinical trials. So again, that's another reason why I always encourage patients to seek care in expert centers so you get that access to clinical trials. A lot of the immunotherapies are still in development. We're looking for some FDA approvals later on in this year, looking at, for instance, CAR T cell therapies and bispecific antibodies. There's a lot of work being done. And I think this is the next line of story in terms of immunotherapy and how we can really engage the immune system to attack myeloma.
And then I have another question. In terms of, could you just speak to us about the level of care? I mean, I tend to be biased. I tend to be very much team MSK. Can you just talk to us about the expertise and all that you bring to bear when you have patients?
Oh, that's such a great question. I love that question. Everybody's situation is different, right? Myeloma patients or patients in general, depending on where you live or even how you've trusted, maybe, for instance, your local oncologist, you know, um, along the way. I think one of the things that, for instance, academic centers are really good at is focusing and partnering with local oncologists. However, MSK can also obviously treat patients and give you direct care, to those patients. One of the things that we at MSK are really focusing on is diagnostics. I think I showed you a few slides on that, as well as clinical trials. So it really depends on the situation. If a patient really has a local oncologist that they're comfortable with, we as experts will often work with those local oncologist experts, with those local oncologists to bridge that gap and really feed, for instance, what's the better regimen to go, what's the next line of therapy, or if certain of the high level diagnostics can only be done, through, for instance, MSK or another academic center, that's another layer of accessing care. So it doesn't necessarily just have to be, you go to MSK. We're willing to partner with local people and really do what's right by the patient.
Excellent, excellent. So again, we always strive access the best possible care that you can. And so that's great to know that MSK will help confer with maybe an oncologist that that patient already feels comfortable with, but MSK experts can weigh in. So that's phenomenal. That'll really benefit the patient. We have another question. When should someone consider entering a clinical trial? And another question was, how can I locate clinical trials to participate in?
I love these questions. Access to clinical trials there are clinical trials on all different disease levels. I think I talked to you a little bit about precursor disease states, MGUS and smoldering. The mantra for those patients is this: we generally observe. But funny enough, we actually have a clinical trial for those patients too. So even at MSK, for instance, my colleague, Dr. Urvi Shah, has a clinical trial where she's looking at diet in smoldering and MGUS patients to see if that can actually affect whether or not MGUS or smoldering patients will progress in the future just based on what they eat. So you would be surprised, there are clinical trials for everything. The best way to access clinical trials directly is clinicaltrials.gov. There are other myeloma specific websites that can also help along the way. I think Spark Cures is another one that's off the top of my head. They
Yeah,
can actually,
Fox Cures is here today.
oh, lovely.
Yeah,
Well, they're fantastic.
yes, thank you. So they'll appreciate the shout out.
Yeah, and they're really good at actually helping a patient, maybe with a local oncologist, say, okay, what therapies have you received? Maybe go down this direct line of therapies to access. So it's actually kind of taking into consideration what you've received already.
Awesome, awesome. All right, well, I think we're starting to wrap up. We actually have Brian from Sparks Cure. He is there. He's in the exhibit hall. Make sure you all go over and say hello. Also, Memorial Sloan Kettering has brought a team of people to our program today. They are in the exhibit hall and they're willing to meet and greet. Looking forward to meeting everyone, to talk a little bit about the process and what's going on in terms of cancer treatment and what MSK has to offer. Do you have one last thing to share, Dr. Korde?
No, I would just say just keep asking questions of your doctors. I think forums like this, I have to say again, a shout out to you guys. It's just so important to get knowledge and information out first. Don't be fearful. I know it's overwhelming with a cancer diagnosis, but empower yourself with knowledge, and that will always get you somewhere. That's how I feel.
Absolutely, absolutely. So thank you again. We thank Memorial Sloan Kettering for their wonderful partnership. Again, we're going to honor one of Dr. Curry's colleagues this afternoon, Dr. Carol Brown. So please be with us at 4:50. Uh, that's it. Thank you. And we'll see you at the next session. Have a good afternoon.
Thank you.